So without further ado, we had some questions that we have from last time. So we're going to make our way down this, and Therese has seen these slides for us at different points to help focus us. The first was regrounding on the difference between an eating disorder versus disordered eating. And
yes, and I just wanted to clarify also the September lecture on September 21st. We did cover a lot of the measurement tools in August. September, I'm going to focus, so it's changed just a little bit based on me. September is going to focus on treatment. What are the current evidence-based treatment modalities? How to access those? So in September, we will be focusing more on treatment. So the first question that Hillary just read, and these questions have been sent in by people that have been participating in this series. So thank you to all of you who have sent questions in advance. I was able to go through most of these in the past couple of days. So the difference between eating disorder and disordered eating, good question. Eating disorders would encompass those disorders that you can formally diagnose using the DSM-5 criteria, okay? So they're ones that you can attach that formal DSM-5 diagnosis to. Disordered eating is much more broad, and it can encompass everything from what I call chaotic eating, which many people do, and they don't like it, but their eating is just lacking in structure. They may skip meals. So with disordered eating, you may see some of those behaviors that we see with diagnosed eating disorders, but they're less frequent, maybe less intense. They may bother the person less so. You don't see the overwhelming amount of dissatisfaction that you see often with people with full-blown diagnosed eating disorders. But along this thought, people are now promoting a whole different schema for both diagnosing and categorizing eating disorders and disordered eating. So stay tuned. I think in the next few years, we're going to see something coming out that is more like eating disorders spectral, or disordered eating spectral disorders coming out. So they'll be attaching more of a spectrum, because these are spectral disorders, and it's sometimes difficult to just peg a person as one thing or another.
thanks, Therese. So the next one, in a similar vein really, is for you to talk maybe a little bit more, or review again, who is at high risk for an eating disorder? So who should a clinician or whoever's here be paying most attention to?
Well, this day and age, I would almost say any person is at risk for an eating disorder, but especially people experiencing higher levels of anxiety, as anxiety is a very potent trigger and maintainer of disordered eating, people experiencing emotional dysregulation. And probably the biggest group, the first group one thinks of as being at high risk, are adolescents. So pre-pubertal children up through adolescence, young adulthood, since their brains are changing. And all of us, anybody in any type of behavioral field or healthcare field, has seen kids and adolescents experiencing increased anxiety. And then, of course, any person who's in a sport or a profession where body image is kind of highlighted and key and central, or thought to be central to one's performance, they tend to be at high risk. So those, I think, are the main categories. Also, people going through life transitions that involve aspects of their body. So women post-pregnancy, women pre and post-menopausal, also people with metabolic disorders like polycystic ovary syndrome and diabetes, which affect their body's metabolism to a great degree.
Thank you. And one of the questions, or you've mentioned a few times across the lectures, men and boys and eating disorders, and I think we all appreciate that that's probably often underrepresented. It's seen as that female thing, and so I would appreciate you spending a few minutes just talking a little bit more about men and boys. From a personal perspective, I've worked with a number of young people in schools, and the pressure for boys to put on or lose weight to be on wrestling teams was the example I came across. It was pretty extreme, and had led to certainly a couple of those young people developing issues with food because of that hyper focus by coaches on you've got to meet weight and all of those things. So just if you could give us a few pointers on that, so that goes up in awareness, that would be great.
Yeah, really good point, Hillary, that illustrates how some sports really, they just drill down on people in terms of you have to make weight, you have to look a certain way, and men and boys certainly don't escape that if they're in certain sports. So regarding men and boys, I think one of the biggest issues, and I still have heard it recently, is that people think of eating disorders as a girl's disease. In fact, I had a young man, he was 25, he went to the PCP, he had quite precipitous weight loss. He had been overweight, and I will say I've seen quite a few boys with restrictive type eating disorders start out with somebody saying they're clinically overweight. Maybe it was the PCP, maybe they were teased at school for being chubby, but this, for some boys, this just causes undue anxiety. But like I was saying, I had a 25-year-old man who had started out, he was considered clinically overweight, he lost quite a bit of weight, he went to his PCP, he was medically unstable at that point. And the PCP said, well, why do you have a girl's disease? So this is one thing. And a lot of the testing and research has been done in the female population versus the male population, which has also led to some of this. But I have to say, the men and boys that I've seen, men with anorexia nervosa present with some of the same concerns and fears that women with anorexia nervosa have. A great deal of fear around weight gain and being fat. Boys with ARFID are sometimes a little bit different. I've seen a lot of boys with ARFID who had been diagnosed somewhere on the autism spectrum. So they tended to have sensory issues. Some of the boys fell into the ARFID category of highly selective eating. I mean, highly selective eating, which I'll talk about in a little bit because somebody did ask a particular question about ARFID. So, and finally, I've put together some slides which will be available on the OHA website with some specific papers. I have a favorite paper on eating disorders in men and boys, which will be attached to some slides. It's a great place to start. It discusses all the different issues and it's extremely well referenced. So you'll be getting that paper as well.
Lovely, thank you. I think it's so hard when we look at populations to know where to put the focus, isn't it? You know, older adults or whatever it is that comes into view. Every pocket can have somebody experiencing an eating disorder. So thank you for putting the spotlight on men and boys. I think we probably covered this last time, but I'm going to ask it again. When someone's doing a nutritional evaluation, which you talked about extensively last time, remind us again what some of the red flags are if somebody's doing that assessment.
Well, I often use the nutrition evaluation as a conversation starter, and I start with frequently the 5 to 7 day food record. So I like to get that snapshot of just how is a person eating. And that's a really good place to start picking up the red flags. So I'm looking at things like, do they eat the same thing every day, indicating a lot of rigidity around food and possible food rules. So rigidity and food rules are red flags. Or I look at, are there specific food groups just left out? Again, pointing to possible food rules. When I'm talking over the person's dietary record with them, I'll ask them to tell me about different aspects. Like, you know, it looks like you don't eat very much protein. So I am looking for key nutrients. Protein, we have definite requirements for protein. And if they're getting too little, I start that conversation. So definitely another red flag is, are they leaving out certain foods that means their nutrient intake is just woefully inadequate? Sometimes it's readily apparent that a person is eating in a way that you might see binge eating behaviors. And so then you can start that conversation. How much does this concern them? Because there is some thought that, is binge eating really a disorder? Is it a normal reaction to something? So people have a lot of thoughts about binge eating, but I like to start the conversation. How much do occasional binges or maybe frequent binges disrupt a person's life or cause them to feel shame or anxiety? So that's another kind of red flag, is, are there binges? And then of course that leads to the conversation of, do you do anything to undo the binge? So ferreting out purging behaviors. So again, I like to start with, how is the person eating? And then start parceling through, because that tells you a lot and points to a lot of red flags.
So there was just a question that popped in the chat, which is, have you got any thoughts then on vegetarianism or veganism? Is that kind of, where does that head in terms of red flags?
Well, in the eating disorders field, traditionally, it has always popped up as a red flag. In fact, traditionally, treatment centers would not allow vegetarianism or veganism.
Wow.
Now, as a nutritionist, I don't see these necessarily as issues, because the research is abundantly clear that one can eat well and adequately, either as an ovo-lacto vegetarian or a vegan. In fact, I just did a seminar earlier this year with Marcia Heron on vegetarianism and veganism and eating disorders. So of course, for the therapist and dietitian, we have to parcel through a person's reasons for being vegetarian or vegan. And then as a nutritionist, I'm looking at, are you eating adequately? And so, for example, in my office, if somebody says, well, I'm vegan, you know, I'm against animal cruelty. I mean, that's a great reason to be vegan. But then I'll say, well, being vegan is no problem. I'm a nutritionist. You can do vegan, but you have to do it right. So that means you have to have plenty of protein, plenty of carbohydrate, plenty of fat. And I emphasize in a loud voice sometimes. And then I wait for the micro expression. You know, if somebody's using veganism as a cover to actually restrict, which veganism doesn't mean you're restrictive eating. We'll go through what it adequately means. You have to eat a variety of foods, all those legumes, plant-based fats, nuts, seeds, so on and so forth. So yes, it can be a red flag, and it means that we as clinicians have to know how to parcel through the conversation to get at what eating in this style means to a person. And it can't be enabling the eating disorder.
Okay, and I was asked one other question. Can you define ovo-lacto vegetarian, which is my long word?
They eat eggs and milk.
And
Ovo, eggs, lacto, milk.
Okay,
but they're not eating animal meats.
Right. So I'm going to move into some other questions. So and skip around a little bit from the list. I'm going to move to one which was of interest, which is you've got a 15-year-old female who really is in probably denial of the eating disorder. So you've got family all around them who are saying there's something going on. But your 15-year-old is saying that's ridiculous. Don't be so silly. I don't have a problem. What are the recommended strategies for getting that person who may or may not have an eating disorder to realize it and accept it?
So they're 15, and you did say they have family all around them. So I'm assuming parents, extended family, all these family members think that there's a problem, correct?
Yeah.
And that's good. It's good if the family is anxious and worried. So then you have a 15-year-old, and I've been trained in and have presented on family-based treatment, which we'll cover in September. So I say to, as far as the 15-year-old accepting this, I don't care if they accept it or not. I don't care if they want to engage in treatment or not. And this is a big difference from kind of where the field was 10 to 15 years ago. 15 years ago, people would do sort of motivational interviewing and try to improve the teenagers' motivation to change. I don't think it works. I say to 14 and 15-year-olds, okay, I also use what I call a play dumb strategy at the front end. I say, you know, your doctor, so included in people all around them being concerned, let's hope the pediatrician also is. So I've done a lot of work with pediatricians. If they aren't concerned yet, let's get them concerned. So now you have the family and the PCP all saying, yes, there's an issue, and we've got lots of measurement tools to show that there is an issue. And I might sit down with the teenager and say, you know, I don't really know you. I don't know how you're eating, but let's take a look. Let's see how it's going. I'll describe normal eating and start off with absence of fear, absence of over concern. So I kind of pull them along, and it's like, is this you? You know, I'll describe sort of what an eating disorder is, how it comes on, what other teenagers have told me it feels like. And I'll invite this teenager to sort of say, yes, that's me. No, that isn't me. But at the end of the day, we initiate family-based treatment, which is not contingent upon the teenager agreeing that there's a problem or being motivated to change. So very different tenets with family-based treatment.
Okay, great.
I will often say to the adolescent, you may not like anything I'm doing, but guess what? You don't have to.
Right. And so we'll talk about this more, I presume, when we get into the whole treatment conversation next. So linked to that, somebody asked, are meal coaches recommended these days? And if you need meal coaches, how do you find somebody like that? How do you link into that kind of system?
We'll also be looking at that when we cover treatment. So a meal coach for an adolescent, a child or adolescent, is usually a family member. And I am using family broadly. I've used grandparents, aunts, uncles, siblings at times if they're much older, but most frequently it's parents. So we'll be talking about what meal support and meal coaching looks like. With adults, there's a fairly new treatment modality that we will also cover called temperament-based treatment with supports. Supports then become the meal coach. Now, there are a few businesses where meal coaches are available to employ. The trouble is insurance may not cover that, so it can be expensive. Usually trained meal coaches are therapists or dietitians. In treatment centers, therapists and dietitians are in the milieu at the meals, coaching people through the meals. So it kind of depends if we're talking at a treatment center versus outpatient. Outpatient temperament-based treatment with supports, like I said, is used for adults, and it's where you train support people that the adult patient has chosen, like these are my support people, and you train them to not only appreciate the unique temperament of this person with an eating disorder, but to use temperament traits to help them make it through meals and other food related situations. So that's also coming up in September.
Okay, we did a little preview there. So next question, when someone's had extreme weight loss and they're experiencing depression and they might even be experiencing some suicidality, where do we go first with treatment on that kind of things? The depression or the eating disorder, the chicken or the egg? Any thoughts on how you deal with the comorbid situations that arise?
Well, certainly if there's suicidality to the point where a person may need, hospitalization to deal with that, that would come first. So you have to deal with suicidality first in the classic way that mental health professionals are trained to deal with that. Then if it's depression plus an eating disorder, and you did say there was extreme weight loss, so starvation itself can produce depression. People who are really starved are depressed. That just happens. So you treat them in tandem. You both, the dietitian and the therapist work back and forth. You set up a meal plan. So you deal with both the depression and the weight loss and the effects of starvation at the same time. And you make sure the person's starting to get adequately nourished, because there's some micronutrient deficiencies which lead to depressive symptoms. One of the classic symptoms of niacin deficiency is psychosis, for example.
Okay.
Thiamine is often lacking. Thiamine has a fast half-life. You can become deficient in a couple weeks. That can affect your mental state. So getting somebody renourished, then the therapist can reset the baseline. Does the depression and anxiety move as the person is renourished? And often we see that it does.
You're making a really good argument for making sure somebody does a good nutritional analysis before they start other treatments to make sure that's not complicating the picture. Thank you. So compulsive exercise with athletes that, how far does that become compulsive exercise with their sports? How do you navigate that if that's part of the story that they're an athlete and yeah, that really complicates things.
It does. And we did cover the compulsive exercise test as a measurement tool in the August 10th lecture. So you can use that. But the other thing is, I'll just give a bit of history. 15, 20 years ago, people would just say no exercise, and the person can't go back to exercise. Exercise was considered kind of a villainous thing, especially with restrictive eating. Now people realize, exercise does have benefits. It has mental health benefits. There are programs. Brian Cook, I think, is advising Alsana treatment programs, and he's an exercise physiologist. People are seeing there's benefits to exercise, so it isn't just totally tossed out of the window. However, if somebody's medically compromised in terms of cardiac function, if they're anemic, if they have stress fractures, there's certain medical reasons to pause exercise until they're medically stable. So usually if somebody's medically unstable, you do pause exercise until they become medically stable, which is difficult if a person truly is compulsive about exercise, meaning they can't take time off even though it's medically advised.
Right.
So then we have to deal with those compulsions, that kind of OCD aspect of the exercise. And that's pretty difficult. On the slides that I made for today, I do have a really good paper dealing with compulsive exercise.
Right. And we should be able to get that paper up onto our website within 24 hours for those of you who are in and
I can
going.
share the slides at the end of this, but it'll be on the website. So I
Right, and then
didn't
you'll be
need a
able to click the
paper.
link. Yeah, which will be easier for folks, I suspect.
Mm-hmm.
So, okay, we're making sure that all of these things will be available to you all afterwards. So when you think about behavioral health providers and eating disorders, what are your favorite trainings for behavioral health providers, apart from telling them to come watch this series?
Well, this is a good one. I think, you know, if you can attend, and they've been virtual the past couple of years, if you can attend the International Association for Eating Disorder Professionals conference and take the core courses, I think that's a good place. Also the Academy for Eating Disorder conference. So those are kind of two of the big conferences where you will see quite a bit of good information. Also, there is an entity called EDRD Pro, run by Sumner Brooks out of Portland, Oregon. EDRD Pro. It costs $35 a month. Wonderful source of information. A wonderful. Every Monday, she'll send you this huge list of reading materials and webinars, and for your $35 a month, you can see all tons of webinars and little talks, and they set up meetings with people so that you can have clinical case consults. So that's it's a really good bargain.
Right.
And even though it says EDRD Pro, there's plenty of therapists. I'm a person who doesn't think that eating disorder specialists are in silos. I think first, there's a giant overlap of knowledge that therapists, dietitians, nurses, medical doctors, if you're an eating disorder specialist, have to have. And then we branch out with some of our specialty things that we do.
Right. Thank you. Let's talk a little bit about schools and school-based things. We may have touched on this before, but we just talked about what would you get behavioral health providers to go to find more information. What about for schools in particular? Are there some resources that you'd be saying every school counselor should have read, or that might be helpful for folks who are, I don't know, the health teacher that people here could share?
That, you know, I've done lots of lectures for schools, and I think eating disorder basics, kind of like what we shared, if you go back to the very first lecture of this series in June, where we talk about what are eating disorders, and you get comfortable with that subject and some of those resources, giving that information, because I find if people are unfamiliar with eating disorders, the first things they need to know or be comfortable with or get under their belt is, what exactly are we talking about? What are eating disorders? Because there's all these myths. So you can go into a room full of teachers or school administrators, and just all the myths start flying out. So we need to calm that down. So going back to the first lecture and accessing some of those resources, such as the Academy for Eating Disorders nutrition guidelines, even though it says nutrition guidelines, it's very multidisciplinary. It's supposed to be multidisciplinary, and we talk about what are eating disorders. Also, in the first series of slides, we have the 9 truths from the Academy for Eating Disorders. I included a few flyers. So printing out some of those things, you can go to the Academy for Eating Disorders homepage and access lots of publications for the lay public, for professionals, for parents. So I think one of the first things is just helping to reduce the myths. And then places like schools, public health, health departments, county health departments, if they could just start with screening screening people and then referring them on, that would be a huge step towards helping us get more early recognition.
And what would be some of your don'ts for that population? I know we've personally talked about this before, things that health teachers do that are just like red flag moments for you.
Yeah, like white hot red flag, white hot flags. I want to get, if I had my personal wishes, it would be to get discussions about food, diet, BMI out of school health classes. Kids should not be counting grams of sugar or fat or any of this. You're trying to do nutrition intervention with a big population when really it should be individualized. That's something to empower parents and the pediatrician to do. So all of this stuff about bad food, and I've heard so much of it over the past 15, 20 years. I mean, it just turns my stomach what I hear coming out of health classes. And sometimes that's the trigger for people. They start judging themselves and, oh, I should be a certain BMI, I should be this, I should be that. And we'll be in December, we're going to talk a lot about weight stigma. So we'll drill into some of this a little bit more and how some of what is actually being said in health classes is totally not true. But any message about food given to a big population, especially kids, needs to be a positive versus a negative message. So yes, it's okay to talk about hydration, pretty neutral. You need to drink enough water, or fruits and vegetables. Research has shown most kids don't eat enough fruits and vegetables. So you need X servings of fruits and vegetables. Recommended servings are this, not eat fruits and vegetables to dampen your appetite so you eat less carbohydrate so you don't get fat. So much of the school curriculum I've heard is really based in hardcore fat phobia. And we need to get that out. And we need to have teachers stop judging parents and kids for what they eat. Anyhow, I could spend hours on this subject, but any
I know. Yeah, I
discussion
know you've seen it, you know, lived through
yeah.
it with parents and children in where you work. So thank you. But I think it's an important message for the audience today to just hear that. And so someone online is a school-based mental health provider, and they're saying, would you screen everybody then in schools for this, or are you waiting for red flags?
I think as a counselor, I mean, wait for some red flags. I think if you screen everybody, it can maybe generate some self-consciousness. But I would, you know, between the parents, the teachers, and the school counselors and the school nurses, if you start to notice red flags in a kid, certainly screen them.
And I should say this is someone who's actually a mental health provider. So if they're doing an assessment, should they add a few food questions into that?
Sure, it doesn't hurt to sort of say, do you have good access to food? Do you feel like your eating is good for you? Is it serving you well? Like, start with some really gentle questions. Do you ever worry a lot about how you're eating? And just kind of see what happens.
Right. Thank you. That's really helpful. I've got one that's slightly tangential to this, but is interesting to me as someone who's had, you know, my PCP say this. Intermittent fasting is what are your thoughts on intermittent fasting? You know, that's been recommended as the current trend, you know, stop doing breakfast.
And current trend for what?
I don't know. Well, certainly for me, it was like, well, if you want to lose weight, you should do
Bingo.
intermittent fasting.
Current trend for weight loss. The research is abundantly clear that most weight loss attempts, first of all, does the person need to lose weight? Why are we going down this road? Where is that coming from? The research is pretty clear that weight loss attempts by and large fail. So yeah, intermittent fasting, any form of dieting, I'm against. I'm a non-diet nutritionist. I don't go there. If a
Okay.
person wants to eat for metabolic fitness, we can have that discussion if there's metabolic issues. But again, individualized. I'm just not into these diet trends that tell the whole world, oh, you're too fat, you have to lose weight. Because most of that isn't helpful. It leads to more shame, leads to more dysregulated eating, leads to eating disorders. Yeah, nope.
Okay. Yeah, thank you very much. So eating disorder prevention as opposed to intervention, what would that look like, do you think? Or what are your thoughts on eating disorder prevention?
Everybody adopting kind of the health at every size, weight inclusive approach to thinking. I mean, that's a big stretch, but no, getting rid of worldwide fat phobia, weight stigma, but then drilling down and looking at where we see that in everyday language and actions. And it can come up very subtly until you start becoming sensitive to what this is. So eating disorder prevention has to do with really a couple things. I was just reading an article about binge eating disorder, and it's so highly tied to emotional dysregulation. So again, helping people realize their emotional health, which we could all wax philosophical on how people's emotional health is currently being impacted by the world news. Okay, we won't go there right now, but helping people find places and ways to be calm, centered, mindful, all of that. So taking care of emotional health, but also just really being sensitive to, and we just talked about it, school health classes, intermittent fasting. So much of it has been centered around obesity. I mean, for what, 2 decades? We saw it coming in the 80s, the childhood obesity epidemic. Oh, here we go. And what a disaster. All this language and supposed efforts for the public good, it's been a disaster. So really prevention is helping people accept the fact that there are different types of bodies. Fatness in and of itself is not a health risk. So again, I'm kind of touching on some of where we'll go in December, but I'll present you data to back up what I just said.
Right, thank you. I think it's so hard as we start to define and design programs as to how we get up to the before it happens. So I think it's a really useful conversation as we move forward to see how that looks and what we might do. One of the questions was, sometimes symptoms in somebody with an eating disorder can seem mild, and so people don't really want to make referrals. This was the comment in the question, partly because there's such a shortage of providers. How do you decide where to go with somebody? Have you got thoughts on how bad is bad and when somebody needs to go find someone to help? I think it's difficult for parents, but I'm guessing it's also difficult for school staff who are maybe suspecting, those kinds of settings.
I think if it's possible with a person like that, just start tracking their eating, and I think therapists can do this as well as dietitians, as well as school nurses. Their pediatrician can certainly, if it's an adult child or adolescent, track their growth charts. Just make sure maybe their eating is chaotic, maybe some of their eating behaviors are off, but track growth charts, have them go to the pediatrician. Just make sure they're growing. Because if you start seeing growth chart, trajectories going off, if you start seeing, increase in disordered eating behaviors, then you have to really intervene. So you might see somebody with mild behaviors. I think that's an indication to, use what you have locally to just track them. A lot of pediatrician offices also have dietitians. Just have the dietitians start to, over time, maybe once every 2 weeks, once a month, depending on what you're seeing and depending on rate of change of behaviors, just have them really look at the person's eating.
Okay, thank you. Someone had a detailed question about intensive treatment. So I'm going to, they must be providing bridge care until the client gets into more intensive treatment services. What are the tools and interventions you think are most important when you're bridging, believing that someone's needing to go into something more intensive?
So what are the things that you should really pay attention to if you're providing kind of that bridge?
Yeah.
Care?
So you're stuck because you can't get them in somewhere. What do you need to be focusing on the most, I think, is the heart of the
Well,
question.
medical stability. So if there's any chance that they could become medically unstable. In fact, I recently had a person kind of like this, and the parents contacted me. I was no longer seeing them, but the parents contacted me and said they felt their child was relapsing at college. And I said, get them to go to student health. Have a student health, a nurse or a doctor at student health look at, cardiac function, vitals, da da da. She went to student health. They referred her immediately to inpatient for medical stabilization up in
Wow.
Portland. So
Okay.
medical stabilization, suicidality, those worsening, dangerous mental health, self-harm kinds of behaviors. So those two things, possible threats to life.
Right. So paying attention to those things first. So,
Mhm.
Katie, did that answer your question? If not, you could just put your hand up and we will unmute you.
Yeah.
I can, so do you think that folks should have things like scales at home? Is that another thing that is unhelpful? So someone is able to weigh every morning, or?
It depends on the person. I think more and more we're seeing kind of individualized care. I've mentioned a few instances where, in the past it was just applied to everybody. Nobody can be vegan, nobody can exercise, nobody can have a scale at home. I'm certainly don't advise, like, for a lot of the children and adolescents who can get into very compulsive weighing, just get rid of the scale. For most people, having a scale at home isn't helpful. They can get weighed at the doctor's office or the dietitian's office or the therapist's office, because eating disorder recovery and cessation of behaviors isn't just about weight. So we're trying to move away from, let's just focus on weight.
Right. It's the deeper emotional side to the whole piece.
It's, what behaviors are you seeing? And for some people, compulsive weighing is a problematic behavior.
Okay. And when would you recommend an orthostatic pressure check?
Well, anytime if you've seen weight loss, fast rate of weight loss, certainly then. If you think a person hasn't been hydrating themselves adequately, or maybe they're purging excessively, and could be dehydrated or have an electrolyte imbalance, any of those, but certainly with precipitous weight loss or a great deal of weight loss over time, I would check orthostats.
Okay, and then there's another one. If someone's sleepwalking and eating, would you consider that a sleep disorder or an eating disorder?
Well, gosh, that's a kind of a tough one. Um, I think I would consider it first as, I mean, I'm not a sleep expert,
Right.
but it also, I would ask the question, like, is there any kind of disordered eating during the day? is the eating during sleep upsetting the person? Is there risk of choking? Like if you're asleep and you're eating, could you choke? I mean, to me, it sounds almost more like a sleep disorder, but again, I'm not a sleep disorder expert. But then I
Right.
would ask the further question, is this eating problematic for the person? Because these are the same questions we're asking about binge eating disorder. So you binge eat on occasion. Is this a problem? Is it not a problem? How does the person feel about it? And
Right.
is there anything in terms of their eating happening during the day? For example, if they're eating at night, do they feel like they have to restrict or purge when they're awake?
Right. So trying to take a look at the whole person and the whole
Mm,
pic. Yeah. Yeah.
mhm.
So we have someone with their hand up. I don't know whether, I don't see a name against it. It's got some letters. So I'm going to bring them off mute to ask their question. I'm hoping that LCHSACXK1, if you're still there and want to ask a question, you've been unmuted. If you want to ask that question, or you can unmute. Note the hand's gone down, so maybe their question was also in the chat. Talking about someone who's experienced an eating disorder, if they've come back out and they've been in treatment, how do you support them as they continue to navigate through their eating disorder, if they're still, as they go through this recovery period, hopefully, or as they continue to live with an eating disorder?
So it sounds like it's a person who's maybe gone to treatment and then they've come back out and reestablished with
Still
a
not really
therapist,
accepting that they've got a problem. Yes.
accepting or not accepting.
Not
What did you
accepting
say?
they have a problem.
So
Yeah,
they've gone through treatment, but they still don't think they have a problem?
yeah, I think so.
Mm. Well, sometimes you can use sort of some of the measurement tools that we went through August 10th to kind of evaluate. Again, I like Melanie Jacobs' EDGE tool. It's like, okay, I mean, I would really want to explore with them why they think they do or don't have a problem, like where, everything seems fine. Let's look together. Is everything fine? Oftentimes people come out of treatment centers and they may be weight restored, nutritionally restored, medically better, but they still have to go through some process to accept what might be a different looking body, or they still might have some desire to engage in some compulsive eating type behaviors. And so, again, kind of working with them, inviting them to explore what could be problematic, what couldn't be problematic. I think acceptance and commitment therapy is sometimes good for that. Like, are you living your most valued life? Like, what does your valued life look like? Is there anything getting in the way? Are any eating behaviors getting in the way? How are they getting in the way? What could be done with that?
Right. And I think from the chat, from the questions, the person's saying that, yeah, this is after long-term treatment and lots of it, that someone's still really in that spot. So I think what you did as the answer covered that, I hope. There's another one in the chat that says, if a client talks about they've got a huge history of, a history of an eating disorder as a child, but it was undiagnosed, but now everything's fine, is that kind of a red flag too? So, yeah.
Well, I would say so. I would explore the statement, now everything is fine. It's like, okay, I mean, and as a nutritionist, I'd say, well, do you want to look at this? I mean, I guess if this is an adult, it's like, okay, well, would you like to look at this? Do you want to see if you have any nutrient deficiencies, or let's just look at your intake. Let's get that snapshot of your intake, if they're interested. I mean, you
Yeah.
can't force an adult, but Yeah, often. And sometimes people do snap out of it. Sometimes people go through the tumultuous pre-adolescent, adolescent years, and they say they've had, restrictive eating or some kind of eating disorder, and they sort of snap out of it on their own. I have met a few people like that, and indeed they are fine.
Yeah, well, that's
But
what we
if
have
there's
to hope. Yeah, that it
yeah,
resolves.
but
Yeah,
if they're sitting in front of you, what are they needing some help with?
right. Thank you. So there was one other question. We've just got a couple of minutes left. I'm sure there are other things, but we have dropped Therese has put resources into her PowerPoint that we'll post that. And so it was restrictive eating versus binge eating disorders and information on that. I'm going to presume, did you put a few things into your slides about binge eating?
Yeah, I have in the slides, there's some good references for binge eating disorder. Also pages 31 to 45 in the Academy for Eating Disorders Nutrition Guidebook, and that's on the slide, especially pages 41 to 45 in the Nutrition Guidebook is specific to binge eating disorder treatment. So, and this is a new diagnosis. Anorexia nervosa has been around for the longest period of time. And then bulimia nervosa was only identified somewhat recently. And then binge eating and ARFID, very new, just the recent DSM-5 has those identified. So you're right, there is more information on the restrictive eating disorders, but do you want me to share my slides?
No, let's, we've only got like 2 minutes left.
Okay.
So we will make sure that those go up within 24 hours because I know Sam's
Okay.
ready to post them. So for those of you who are ready to do some reading and dig into that, that'll all be on the website. And that's where you've been registering. So, and that is the Child and Family Behavioral Health Team site at Oregon Health Authority.
Hey,
So,
Hillary, I thought we went to 1:15.
is that right, Sam? I don't want to close it out, or we can keep going if not, but I thought we were 1 o'clock today for 60 minutes. So
I believe that we had said, yeah.
I mean,
yeah, so we're happy to stay on and have conversation if folks wanted. I think I was just being mindful of us saying it would be 1 o'clock today, I believe.
Yeah, we were allowing to 1:15 in case there were any extra questions. So if anyone does have any further questions, we would love for you to pop them in the chat, or please raise your hand and I will turn your microphone on if you'd like to ask them live. We'll give everyone a few moments.
And then somebody did ask about ARFID. How do you manage this in young children? Again, page 41 in the Nutrition Guidebook has that. But with young children, again, FBT has been adapted to use for ARFID. I've worked with quite a few families with kids with ARFID, and with avoidant restrictive food intake disorder, you do have to kind of parcel out what was the precipitating factor? Why does this person have ARFID? Did they experience choking? Do they have a neurological issue where chewing and swallowing is difficult? In those cases, we often bring in speech pathologists to help with that. So,
right.
yeah, parceling out.
Yeah, someone saying they struggle to diagnose that and how to decide. I mean, I think knowing how many people have picky children as youngsters, when does the picky child become something different where you are more concerned?
Again, monitor growth charts. Yeah, picky eating is sort of a norm in childhood, but monitoring growth charts, when kids start to really falter in terms of longitudinal growth, both height and weight, then we get concerned. And I can give you an example. I had the 10-year-old boy referred to me from his therapist, And he was just a classic picky eater. He would fall into the ARFID category of a highly selective eater. He would only eat about 12 foods: peanut butter, chocolate chips, goldfish crackers, one other type of cracker, one certain type of bread, one certain type of chicken nugget. I mean, very specific. And I first collected a nutrition intake that his parents, I coached them very diligently to provide extremely accurate amounts of the food. I ran a nutrient analysis, and guess what? And I've seen this in quite a few of the highly selective eaters. He was eating adequately. He was growing just fine according to his growth charts. And so during one of my meetings with his parents, his mother piped up and she said, you know, I'm so glad there's finally a name for this, because this is me. I was like this. And she was a highly successful teacher. She successfully had 3 pregnancies, which means she was not starving. She was not malnourished. But for people like this, and we don't know if it's neurological, taste bud issues, what? Eating is not exciting to them. So she said, I was never excited about Thanksgiving dinner or anything like this. Same with my son. She goes, when I got to my 20s, I kind of forced myself to try a few new foods because I wanted to be able to go out to dinner with my husband and another couple. So she had a reason to try new foods. Did she have a huge expanded repertoire of foods? No. But the problem with people like that, and she validated it, you know, so as long as, so he was eating adequately. I think we gave him a little bit of a multivitamin to address a few micronutrient deficiencies, like maybe iron, but he was eating enough calories, enough protein, he was growing. The problem is more a problem for the people around folks like that. And she said, yes, it was much more of an issue for my friends and my family because I wouldn't sit down and eat a pizza, you know? And I said, the issue then becomes coaching the families to change their expectations of how this person eats, and then give this young 10-year-old some verbiage so he can come back at those around him and help them manage their own anxiety about his eating. So letting him know you're eating just fine, you just have a certain way of eating, but it works for you. Because I had one young man, very similar, same story. His father offered to give him $350 if he would eat a hamburger. The father was really into grilling steaks and hamburgers. The father loved that. His son didn't like meat. He was kind of an ovo-lacto vegetarian, but he was growing. His nutrient intake was adequate. So really we had to manage dad more than this kid, because dad was distraught that his son would not sit down and have a hamburger with him. So you can see how, you know, it becomes a question of whose problem is this really?
Right, the system piece. Do you have information on highly selective eaters? Someone was asking.
I can dig that up for you. If it's not in, I have a couple of good ARFID references. But yeah, I had consultation with Dr. Julie O'Toole, who was the founder of Cartini Clinic, and she helped write the DSM criteria for ARFID. And I remember talking to her and we both agreed this certain category of kids who were highly selective eaters, they were eating pretty okay. They were growing, but you would be hard pressed to change their eating. Like this little boy, the 10-year-old, the parents had to order, they were actually doing work in another country. They had to order the goldfish crackers from the United States because he could tell the difference based on the different oils of the goldfish crackers made in Europe versus the goldfish crackers made in the US. I mean, that is some sort of a talent.
That is, isn't it? Yes, yes. And so where does ARFID fit an autism on that spectrum? Is there some kind of link?
There's some overlap. There's definitely overlap. I had a young man. He was just 19, 20, and he was diagnosed with autism, and eating, it was pleasurable for him sometimes, but he would oftentimes just forget. So we had to kind of set up cues for him. We had to figure out what would work to set up cues for him to remind him to eat, because he might get involved in some other activity and he would go all day and not eat. And so sometimes there are overlaps, sensory processing issues, neurodivergency.
Thank you. And so, yes, I think that would be helpful if you do have some particular links on.
Okay.
I think that would be great. I've got
No,
one.
it's a fascinating field, and I think it's emerging still.
Right. And I have one that's a different sort of question. So gastric bypass surgery for severely overweight individuals. Yes. Or for individuals suffering emotional overeating. What are your thoughts on surgery as an option, I guess, is coming in from Betsy. And I think we saw the answer on your face there, actually, but
yeah, right. I don't love it. In the eating disorder worldwide community, gastric surgery is somewhat frowned upon because we often see people post-surgery where the surgery has failed. I've had several people where the surgery has failed. They still figure out how to overeat, or binge eat. And so really, I think emotional regulation is more the key if people have compulsive overeating and they're greatly bothered by that. So yeah, we've just seen so many failures with bypass. And I had a psychiatrist friend who often saw people before and after those surgeries. And she, because of the tremendous brain-gut connection, you've now taken out part of someone's gut. And this psychiatrist swore there were personality alterations once part of the gut was removed.
wow, fascinating. Yeah.
Mm-hmm. So personally, I don't like it because I've seen quite a few people post-surgery and it hasn't worked for them.
Right. Yeah, thank you. I think we also had one question around force feeding. Is that something that people do these days, these treatment settings, or
in general, you try not to force feed. The only cases, there are some well, if a person is in a treatment center and they're an adult and they have elected to be in the treatment center and it's too difficult to actually eat, to put food in the mouth and chew and swallow, some people will elect for an NG tube feeding. I've read of a few cases where an NG tube feeding is done at night. They would prefer to be asleep while receiving this form of nutrition, but that's what's helping them stay alive. In pediatric cases, if you have to medically stabilize a child in the hospital, they will do an NG tube feed. And oftentimes it is against the child's will. Sometimes they have to use some sort of calming medication. So that's where it might be considered forcible feeding.
right?
So in those cases, but again, you're up against, we have to get some nutrients in this person or it could be life compromising.
Right. Yeah. And yes.
But as far as violent, like let's pin them down and force this spoon in their mouth, we don't do that. We would go to an NG tube feed.
Right. Thank you. And yes, the compassion around that for families and for young people or adults facing those decisions is just huge, isn't it? It's like to be in that extreme of a position. So when we think about, as a last question, I think, when we think about suggesting approaching treatment and how to do that, what are the compassionate or considerate ways that mental health and medical practitioners can use that? And I think you've talked a lot about that in the words that you've used today about how to do this approach with folks, but any other thoughts about how people tackle this story, or also how you educate a professional to be more compassionate around it?
Well, we will be covering a lot of this in the September lecture, in the kind of portion, starting the conversation, how to talk to people. I think with adults, using acceptance and commitment therapy is a good starting approach. Motivational interviewing has also been used with adults. A lot of people don't recommend motivational interviewing with children and adolescents because they're just not at the place mentally where you can access sort of that motivational aspect. But with adults, really engaging them in a conversation where they can see where their behaviors are interfering with their valued life. Also, I have found that people so appreciate you understanding what an eating disorder is. I say, first off, I get the fact that you didn't choose this. You didn't wake up one day and say, wow, I think it'd be a great idea to have bulimia nervosa. No, nobody wakes up and just chooses this. And oftentimes people are blamed or treated as if they are choosing this. And so people don't choose an eating disorder any more than they choose claustrophobia. Like, who chooses that? No, it's really coming out of that anxiety, fear response. And so talking to people as if, letting them know that you know what an eating disorder is, that you understand, that you have compassion for their urges, their feelings, their fears, that goes a long way. And so, and then once they feel like you're in their corner, like you understand them, then you can say to an adult, okay, can we start talking about how this interferes with your life? And then can we, maybe after that discussion, you talk about, okay, let's look at steps forward. Let's look at what would help, if they're in that place where they're willing to accept help.
Great.
And then with an adolescent, it's a little bit different because oftentimes they don't like it. They don't want to change, but they have that adolescent brain, which is just a lot more chaotic. Their executive functions aren't mature.
Right. And there's thanks in the chat for you for demonstrating this compassion for people with eating disorders. So I want to just wrap us up so we're on time, given that I tried to close early. I'm now on time, apparently.
Okay.
So we will meet again on September the 21st, I think it is, for the next session. And I want to thank everybody for being here today and for feeding me all these great questions. So thank you all for putting that into the chat, and hopefully we managed to keep this moving. And I know I've learned a lot today from you, Therese. So thank you very much again for the time you're putting into this series and being willing to take whatever comes in the questions. And we will make sure we have Therese's slides up really on time, and so you can pick up those extra resources there. So thank you all very much for coming today.
Yeah, thank you for the questions. Excellent questions, everyone.
Thank you.
Thank you all.
Thank you all. We'll see you on September the 21st. If you're not sure if you have signed up, you can email me at sam.lhaskins@dh. Oh, you have the email in your inboxes. Yeah, you said you got the invitation from me, and I can look it up for you.
Okay.
Thank you, Sam. I'm sure